Hello, everyone, and thank you for being here. Thank you for the organizers of the meeting and the chair of the symposium for inviting me to give this talk on serum biomarkers for hepatitis B. So, diving into it, when we look at the role of biomarkers for hepatitis B, there are multiple areas where we need biomarkers. That is diagnosis, treatment, liver cancer risk, and to a lesser extent, there are other needs like reactivation of hepatitis B and occult hepatitis B. Now, going through all of these could be quite impossible in 15 minutes, and I think unnecessary, but I will try to focus a bit on diagnosis and biomarkers for treatment as well. One thing that I would like to emphasize is that when we talk about biomarkers, it's important to remember that we need biomarkers for resource-rich and limited settings. I think we all get excited about novel biomarkers for disease, but most of the damage done by hepatitis B is in resource-limited settings. So, in terms of biomarkers for diagnosis, so I go here, we have the surface antigen that's pretty well standardized. That can be measured by ELISA or point-of-care testing. Point-of-care testing is not necessarily a serum biomarker, can be whole blood, but I think it's important to put it here. And I think here we're doing quite well, to be honest. Point-of-care testing for surface antigen is widely available, it's quite cheap. You can get it for 10 cents a dollar. They are reliable and they are environmentally friendly. So these tests can withstand heat and cold. The WHO endorses 3 point-of-care testing, the BioLam, Vicky, and the Determine2. I personally don't think any of them is better than others. And for those of you that are working in resource-limited settings, I recommend you try to use whatever is your local point-of-care testing. Now, when we look at biomarkers for treatment, is when things start becoming a bit more interesting. The current biomarkers that we have are the hepatitis B DNA, the E antigen and E antibody, and the liver transaminases. There are a lot more than these, but I think for our everyday management of hepatitis B, these are the most common ones. And I'll go through not each of them, but the conjunction of them for treatment initiation, monitoring, and stop. So in order to start treatment, I personally think we have the sufficient tools. We have, as I said, the DNA, antigen, antibody, liver transaminases, and I'm oversimplifying here, but we all know if you have a high DNA and high liver enzymes, you treat your patient. If you have low DNA and low liver enzymes, you don't treat your patients. There are some exceptions in the middle. We actually had quite a discussion yesterday, I think, in one of these exceptions. But I think all in all, we have the tools to determine who should be started on treatment or not. There is a lot of discern and a lot of variation in when to start the treatment, whether you are in China, Asia, the US, or Europe, but I think the tools are actually ready. When we look at current biomarkers for monitoring of treatment, I think we're doing okay as well. The most important ones here are DNA and ALT and AST. And again, I think for our daily practice, if you have somebody with an undetectable DNA, with low liver enzymes, you can say that the virus is suppressed. Where we hit a wall is in when to stop treatment. And that's when the current biomarkers are not particularly helpful. I'm highlighting here the E antigen, E antibody, because in some cases, if you have an E antigen positive patient that seroconverts to E antibody, you could consider stopping treatment in these patients. I'm mentioning also surface antibodies. So if you have somebody with surface antigen that negativize, actually they might not need to develop a surface antibody, but they will. You can also stop treatment in these patients, but we need to keep in mind that these patients are the minority of the cases. So this is the area where we need the most help. Now I want to spend a minute here on cost and availability of the current biomarkers. As I said earlier, surface antigen is very inexpensive and available worldwide. Liver transaminases, they are available worldwide, but to be honest, in my opinion, for how simple of a test they are quite expensive in a lot of places. The E antigen and antibody is actually, I mean, either or of them are really cheap, I think, but they're not very available. I think a lot of people are not aware, but there's a fair amount of point-of-care testing for e-antigen and antibody, and my team has published quite a bit on validating these tests in Latin America, Africa, and Europe, and they're great and they're very cheap, but I think either for lack of awareness or other reasons that people either don't know about this or they don't use this test very much. And then the one that gets the double black is hepatitis B DNA. Hepatitis B DNA is not very available in a lot of places, and it's definitely not cheap. We have made some progress here, so we have a Gene Expert, which is a PCR platform that we use for TB, HCV, or the Philadelphia chromosome, that can actually in one step give you a pretty good assessment of DNA. But you still need to have a machine, and the cost can vary quite a bit depending on where you are. I think there's a fair amount of lateral flow assays that are coming, but we still need a bit of work to do. This is one example of a lateral flow assay paired with a LAMP, a loop-mediated amplification, to try to do a point-of-care test for hepatitis B DNA. And I think there's some work on this that might facilitate assessment in the near future. But this is an area where we definitely need more testing and more research. So the second part of my talk, I'll talk a bit about emerging biomarkers. Now, there are a lot of emerging biomarkers in here. It would be impossible, and honestly speaking, beyond my expertise to talk about all of them. But I will focus on three of them: the surface antigen quantification, the core-related antigen, and the hepatitis B pregenomic RNA. You'll notice that I put the surface antigen quantification in blue, and I did that because actually it has been around for a while, so it could be controversial whether it's emerging or not, but I think it's not widely available, so it's worth talking about it. Where these biomarkers help is in areas that the current biomarkers can't help, which is when to know when to stop treatment and also to assess new treatments. So why do they help here? If you look at the standard treatment, barring interferon, for everyone, we tend to use nucleoside analogs. What these medications do, they actually block the reverse transcription from pregenomic RNA to the relaxed circular DNA, which is eventually what is secreted to the blood. So you start patients in nuc, this process is stopped, and then you see a decrease in DNA. What they don't tell you, what we can't find out from this nuc treatment, is what happens to the covalently closed circular DNA, the cccDNA. And this is a mini chromosome that is basically the backbone for infection of the hepatitis B virus, and its presence can also lead to hepatocellular carcinoma. So these three biomarkers at different degrees and one way or another, they can be used as a reflection in peripheral blood of the presence or not of the cccDNA. So when we look at hepatitis B surface antigen quantification, it has been around for some time with varying success. It's used in Europe, used in Asia, and honestly speaking, we don't use it much in the United States. And it can help you, particularly in hepatitis E antigen negative patients, to know when to stop treatment. The problem is it has a slightly limited role for cure because the surface antigen per se is composed by the covalently closed circular DNA, but also composed by integrated DNA. It is also not widely available. You need to have a certain expertise of laboratory, and the levels vary quite a bit depending on the hepatitis B genotype. Actually, I will refer, I just brought to my attention recently, it was a very nice meta-analysis by Dr. Lim's group looking at variations also on surface antigen based on ethnicity. So I think although this is here and it's been around for a while, there's still some research that needs to be done for surface antigen quantification. Now, the next biomarker, you might or might not be very familiar with it or might have heard of it, which is the core-related antigen. The core-related antigen represents three proteins: the E antigen, the core antigen, and the P22 core-related protein. So it's one biomarker for three proteins, and they don't all have the same influence. The majority, I would say, I think it's 80% of the core-related antigen represents the E antigen. Now, studies have shown a reasonable correlation between the correlated antigen and cccDNA. However, most studies have been made or done in patients with genotypes B and C. Because of the heavy influence of the E antigen in this biomarker, there are large variation of correlated antigen in patients that are E antigen positive or E antigen negative, and there is not great sensitivity of this test, although I'm told that Abbott now has a better test that can be used. If you look at this meta-analysis published a couple of years ago that tried to look at the correlated antigen and how it correlates with the cccDNA, here you can see on the right a correlation coefficient of 0.6, which is acceptable, and you can clearly see that about half of the studies do show a really nice correlation, but the other half of the studies don't show a great correlation between the correlated antigen and the intrahepatic cccDNA. Now again, this is due to multiple things. One of them is the lack of sensitivity and variation of the correlated antigen. Another problem is the detection of the intrahepatic cccDNA. This is not standardized, so different groups do it different. One area that the correlated antigen seems to be quite interesting is in its correlation with hepatocellular carcinoma. There are several studies showing a strong correlation of correlated antigen with HCC. This particular study done in treatment-naive patients, where they basically took a value before started treatment, performed in Southeast Asia, shows here in panel D how if you're above or below a threshold of 2.9 logs of the correlated antigen, you have a really nice correlation with HCC over 10 to 15 years. Do keep in mind that if you look at the other panels, like the genotype on A, the DNA on C, they also correlate quite well. So I think this is an area of interest, but still needs some development. The final biomarker I want to talk to you about is a hepatitis B RNA. Now, hepatitis B RNA does not circulate freely in blood like DNA does. It does so attached to viral capsid complexes. So by measuring via PCR these complexes, you can measure hepatitis B RNA. And for treatment monitoring, if you look at all the entire RNA of the Hep B, it correlates relatively well with hepatitis B DNA. However, one point that is very important is the hepatitis B RNA that is detectable in blood is really formed by 5 different transcripts. And why is this important? Because 3 of these transcripts, the S1, S2, and xRNA, are products of integrated and cccDNA. However, the pregenomic RNA, same as the pre-core RNA, are products of cccDNA exclusively. So one could assume that by amplifying pregenomic RNA, you can have a pretty decent idea of what the intrahepatic level of cccDNA are. And therefore, you can use pregenomic RNA as a direct marker of cccDNA. Again, this is helpful to assess cure, real cure, and it's also helpful to study new medications in patients that are already in NUNCs and you need to measure something else. Now, I do, like with every biomarker, I do urge a word of caution. The initial studies like this one here show a really nice correlation of peripherally detected pregenomic RNA with intrahepatic pregenomic RNA and intrahepatic cccDNA. However, other studies, there are at least 3 that I'm aware, including this one this year, show that pregenomic RNA correlates really well with cccDNA in the liver in hepatitis B E antigen positive patients, as you can see on the left, but not that greatly in hepatitis B E antigen negative patients, as you can see on the right. So, as a summary, I think for the near future in our day-to-day treatment of patients, we still are using the surface antigen, E antigen, and antibody and the hepatitis B DNA. We definitely need better markers for cccDNA so we can understand when to stop treatment and so we can do a better job at discovering new drugs. I do think that the correlated antigen, the pregenomic RNA, and to a certain degree, the quantitation of the surface antigen, all 3 can help here. And I want to emphasize the last point in here. We need better testing for hepatitis B activity, like DNA, in resource-limited settings. We need better biomarkers for hepatitis B DNA. And with that, I will happily take a seat, and thank you very much.